السلام عليكم أعزائي طلبة المرحلة الثانية. باسمه تعالى نبدأ المحاضرة السابعة Physiology of GI Tract. Today we will talk about physiology of some gastrointestinal disorders. راح نتكلم عن بعض الأمراض اللي تصيب الجهاز الهضمي. Starting by esophagus, we have paralysis of swallowing mechanism. شلل عملية البلع. This can be caused by either damage to the 5th, 9, and 10 cranial nerve, the trigeminal, glossopharyngeal, and vagus nerve, or may be caused by damage to the swallowing center caused by poliomyelitis or encephalitis. ممكن يظهر بسبب ضرر إلى مركز البلع بسبب مرض شلل الأطفال اللي يصيب الجهاز العصبي أو التهاب الدماغ. or maybe damage to the swallowing muscle itself، أو ممكن المشكلة بالعضلة نفسها like in muscle dystrophy, myasthenia gravis or botulism. So here the patient will be unable to swallow، فهنا الشخص يكون غير قادر على البلع. failure of glottis to close so that food passes into the lungs instead of esophagus، راح يمر الطعام إلى القصبة الهوائية وإلى الرئة بدل من المرء. failure of soft palate and uvula to close the posterior nares so that food reflexes into the nose during swallowing، فيمر الطعام يرجع الطعام إلى الأنف، الجهة الخلفية للأنف، ويخرج الطعام من الأنف. Another problem, we have achalasia and megaesophagus. Achalasia is a condition in which the lower esophageal sphincter fails to relax during swallowing, and this is caused by damage in the neural network of mesenteric plexus in the lower two-thirds of the esophagus. راح نبين هذا بالشكل بصورة أفضل. The achalasia, the problem is here. There is failure of relaxation of this sphincter, lower esophageal sphincter. It will continue to be contracted، يبقى متقلص while the food should pass from the esophagus to the stomach. المفروض يتحرك الطعام من المرء إلى المعدة راح يبقى الصمام متقلص مسدود. By this the food will be accumulated here and distend the esophagus by time to be larger and larger. Like in this picture, this is barium swallow. هذه صورة أشعة باستخدام الصبغة. فنلاحظ المرء متوسع من الأعلى بينما الجهة السفلية تكون متقلصة like funnel shape، مثل شكل القمع. And here we call this megaesophagus and achalasia, continuous contraction of the lower sphincter. In the stomach we have a common problem, gastritis, inflammation of gastric mucosa, التهاب المعدة. Mild to moderate chronic gastritis is common in the population in the middle of later years. فهذه المشكلة موجودة بكثرة بالأعمار الوسطى والأكبر. If the inflammation of stomach is superficial, so there is no problem. But if it is affecting the deeper layer, so here the problem, and it will cause damage, atrophy to the gastric mucosa. فإذا كان الالتهاب سطحي فلا توجد مشكلة، أما إذا كان الالتهاب عميق فهذا راح يؤدينا إلى ضرر لخلايا وغدد المعدة. The cause of gastritis is usually chronic bacterial infection or maybe irritant substance. فسبب التهاب المعدة ممكن التهاب جرثومي أو استخدام مواد مهيجة like alcohol or aspirin. Gastric barrier normally is resistant enough to diffusion pH. راح نشرح هذا الكلام بالصورة بشكل أوضح. You remember this photo? Here the epithelial cell of stomach and here the mucus layer. The interior of stomach has pH of 2, high acidity, while less acidity near the epithelial cell reaching 7. So the mucus layer here will act as a barrier. هنا راح تعمل المادة المخاطية للمعدة كعازل كحامي from the high acidity. This high acidity not affect the epithelial cell. هذه الحامضية العالية ما تأثر على الخلايا بوجود الحامي هنا العازل. But if any break أي خلل هنا any damage to this barrier, so there will be defect in this number. So the high acidity can reach the epithelial cell. فإذا وجود أي خلل هنا بهذا العازل معناته هذه الحامضية العالية راح توصل إلى خلايا المعدة. And this will cause damage to the cell and damage to the gastric gland. In many people who have chronic gastritis, the mucosa gradually become more and more atrophic. فعندهم التهاب معدة مزمن بمرور الوقت راح يصير عندهم ضمور في غدد الأمعاء. Atrophy of gastric gland or no gastric gland, and this will affect the gastric secretion. Mainly will affect the intrinsic factor and acid secretion. راح نجي عليها بالتفصيل هذه الحالتين. We have achlorhydria and hypochlorhydria. There is absence of hydrochloric acid, or hypo, there is decrease in the hydrochloric acid. And the problem here, we need the acid secretion to convert the pepsinogen into active form, the pepsin, which is so important in the digestion of protein. Without acid secretion, there will be no active pepsin, and there is no digestion of protein. Other problem, we have pernicious anemia. Normally, as you remember, there is intrinsic factor secreted by parietal cell of oxantic gland. هذا العامل ينفرز من المعدة. It is needed to be combined with vitamin B12, and they will go together from stomach to the small intestine together until they will arrive the terminal ileum, and here the intrinsic factor will bind to the receptor, leaving B12 alone to be absorbed. نحتاج هذا العامل حتى يرتبط مع البي 12 بالمعدة، يمشون سوية من المعدة إلى الأمعاء ويحميه من أنزيمات الهضم إلى أن يصل إلى نهاية الأمعاء الدقيقة. عند ذلك الوقت راح يتصل هذا العامل مع الريسبتر ويترك البي 12 وحيدا ليتم امتصاصه في نهاية الأمعاء الدقيقة. So if there is absence of this intrinsic factor, there will be deficiency of B12 because there will be defect in the absorption, and the pernicious anemia will occur. هذا سؤال وارد بالامتحان. What is the mechanism of pernicious anemia? Talk about pernicious anemia. Another problem, peptic ulcer. It is an excoriation of stomach or intestinal mucosa caused by digestive action of gastric juice or upper small intestinal secretion. Here, this figure is just for illustration, للإيضاح فقط ليس للحفظ, showing the site of peptic ulcer, either in the affecting the lesser curvature of stomach, or in the antrum of stomach, or in the pyloric area in the duodenum, or maybe in the lower esophagus, and here in the lower esophagus because reflex of acidity from stomach to the lower esophagus, or marginal ulcer here if there is operation, surgical operation, they are doing jejunostomy, عملية جراحية يربطون الججنة مع المعدة. So here the marginal ulcer will occur. What are the causes of ulcer? Either there is high acidity secretion, there is irritation by alcohol, aspirin, poor blood supply, poor secretion of mucus, the defect in the barrier, or infection by bacteria like Helicobacter pylori. So a peptic ulcer, we have two mechanisms to have peptic ulcer: either excess secretion of acid or there is defect in the barrier. Bacterial infection by Helicobacter pylori is important cause of peptic ulcer. It will break the mucosal barrier. Other factors predisposed to ulcer include smoking, which will increase the nervous stimulation of gland secretion; alcohol, which will break down the mucosal barrier; aspirin, again, will break down the mucosal barrier. So, in treatment, they will treat the Helicobacter pylori by using antibiotic. They will decrease the acid secretion by using acid suppressant drug like ranitidine, antihistamine. And finally, in the pancreas, if we have any problem, there will be defect in the pancreatic enzyme secretion, which is so important in digestion of food. This problem may be pancreatitis, التهاب البنكرياس, or may be pancreatic duct blocked by gallstone at the papilla of Vater, or maybe the head of pancreas has been removed because of malignancy. So any problem in the pancreas will cause great defect in the digestion of food. And thank you so much.